Hi everyone, welcome to PT TV. Today we'll be talking about treating chronic pelvic pain, and I'm joined today by Elizabeth Rummer and Heather DeFord. We were just curious if you both today would tell us a little bit about how you think the best way to treat your patients with chronic pelvic pain becomes symptom-free. And that's obviously a broad question, but...
I think the most important thing is to have a multidisciplinary approach. That's the thing that we focus on the most here. We are a vital component of that treatment plan, but we have to be working with our gynecologist, our urogynecologist, urologist, sex therapists, pain doctors, our orthopedic physical therapist colleagues, because we all have a part to play in this. Pelvic pain is a multimodal various diagnoses, but multimodal, and so you can't just use one type of treatment, so that's something that we really focus on. But as far as what PTs do, we're 100% manually based here. We actually don't utilize any kind of modalities or biofeedback. It's all manual treatments, and those would include connective tissue manipulation, trigger point therapy, of course, internal myofascial release techniques, various and external myofascial techniques, and then structure biomechanics and neuromobilizations.
I have a very similar approach. Definitely agree with the interdisciplinary approach. I do happen to use biofeedback because I use biofeedback for parasympathetic training and teaching the patients to relax from an intrinsic capability. If they're taking medications or not taking medications, I found that using biofeedback to have them be able to see the mind-body connection has been very powerful. I think people talk about how their emotions and stress level can affect their tissue tension, but when they see it on the screen that, oh my gosh, when I start doing intense math problems, or when I start thinking about my, the stresses of my day, my electrical activity in my body increases. And that's just been a very powerful experience for patients. I don't see it as crucial by any means. And I do know some pelvic floor physical therapists will work with a biofeedback technician who will administer and kind of lead people through other parasympathetic training. And, just like Elizabeth said, doing a lot of manual techniques to help release the tension, making sure that their pelvis is symmetrical so that if their pelvic is out of whack, the nerves that try to innervate the muscles and the organs, glands, may not have a free passageway. The lymph may not be able to drain accordingly. So definitely working with orthopedic physical therapists, or I do a lot of my own orthopedic adjustments to make sure that you have a sound structure, as sound as you can get it. So, that goes along with the postural mechanics and therapeutic exercises to maintain the benefits that physical therapy can gain. So, that's just the broad basis of what we do. And in fact, I've heard, I think Elizabeth, you and I had a conversation many years ago by a patient that we kind of worked with from Santa Cruz. She'd come up to see you. Okay. And heard great things about you and your facility. And I think it's really exciting how you have multiple facilities and work so close with the doctors. In doing education about what PTs can offer to this population, I think so often I run into doctors who aren't aware of this as an adjunct to what they're doing. So that's great. Out here in Park City, I have a lot of education to do.
Yeah, it's something that we work on constantly. Working to educate doctors. We're constantly giving in-services or just going and having coffee with doctors, and we give them a quick screening guide that has a whole bunch of questions that cover urinary, bowel, sexual dysfunction, and pelvic pain. Say basically, if your patients answer yes to any of these questions, then it's appropriate to send them for at least a pelvic floor evaluation, and then we can go from there. Right. So it's a lot of education because, as you said, it's not really taught in medical school still. And if it is, it's just maybe in the gynecology world. But I'll tell you, some of our best referral sources and best kind of team members have been urogynecologists, because they seem to really get it. It's been a really interesting and surprising kind of road to see. You'd think that whom you thought would really be your biggest allies aren't necessarily.
Right. Yeah. I think the biggest ally that I have is women talking to women.
Yeah.
And sharing their stories. So I know that you just went to a course on the centralization of pain, and everything that I've learned, about that has been a lot of medication, pharmaceuticals to treat that. And so I'm wondering if you've learned anything of how physical therapy can help break down that centralization process. And maybe you can explain what that is for our viewers.
Yeah, sure. So this has nothing to do with medication at all. So the conference that I was at is the International Pelvic Pain Society, which is the only organization that really focuses solely on pelvic pain. It's a multidisciplinary society, PTs and a range of MDs. And the keynote speaker, as well as he did a post-conference course, was Lorimer Moseley, who I'm sure many of the viewers will know. He's one of the authors of Explain Pain with David Butler. He's a physio from Australia, but he's a neuroscientist. And so they've done an enormous amount of research on how to lessen the central sensitization or facilitation of pain. No medications required, and their basis is really educating the patient about what is pain, and the fact that you don't have to have a nociceptive input to have pain, that there are many other types of inputs that can cause pain. For example, say a woman with dyspareunia or pain with intercourse, just starting to be intimate with her partner may cause pain even before touch, because the pain is essentially sensitized.
Just the thought of it.
Just the thought of it. I mean, we see this with urinary dysfunction all the time. Just the thought of, I need to go to the bathroom, they may leak or their urge may intensify. Just with seeing the bathroom door, putting the key into the door is a classic sign. So these are the techniques that he really discusses, is educating the patients on what really is pain, what can cause it, how to recognize that, and then different ways to deal with it. So it's fantastic stuff. It's really cutting edge. There's only a few PTs in our field in the country that are really doing this in their clinic, because it's education via talk, so it's not really hands-on, which is very unusual for PTs. So we're starting to incorporate in our practice, and it's a really big shift, because we may not touch our patients for the first few sessions. It may just be education before we actually put our hands on it, because the research is showing that if you have a patient that has this kind of facilitatory pain cycle or central sensitization, that their pain may actually increase if you put your hands on them and start doing the work before you do this education. So it's really fascinating stuff, and by no means are we really competent in it yet, but we're super excited to start to incorporate into our practice, and I think it'll be one of these missing links that we've been looking for, because I think as you were kind of alliterating to, that the drugs are an option, and thank goodness they're there for some people, but we need more conservative options to treat this.
And so when you say education, is it bringing out the anatomy books and showing them the central nervous system and how that, breaking it down for them and really explaining how pain works in the body?
Yes, how pain works, that you just because something hurts doesn't mean that there's actually damage happening to the tissue. And so through their books and some of their resources, and there's more and more research coming out about it, there's actually very particular ways to go about teaching them. There's several different courses you go through to teach them all about the different kinds of pain, why pain happens, and and those types of things. So there's a process to go through, but it's really interesting stuff.
Well, and from what I know about it is that it's not particular to pelvic floor pain.
Absolutely.
And so someone who has a herniated disc and they get the disc fixed, and there's no more noxious stimulus on the spine, but they're still experiencing pain. And they talk about how the brain has it hardwired that there's pain there there's no inflammation and there's no noxious stimulation, but how to break that down. And I was curious if you were going to say anything about using, interferential, because I've known that before, interferential stimulation, which is a form of electrical stimulation, which helps recalibrate the nervous system.
Mm-hmm.
So
well,
what do you know about that?
We don't use any kind of stim at all, and we don't necessarily plan on doing that for this type of work. What they're finding is that the pain is just as real. So you're talking about this pain of someone with low back pain, and you're correct. This is for anybody with pain. Most of their research is with complex regional pain syndrome, neck pain, and low back pain. Not really anything in pelvic pain, but it's completely applicable, of course. But the pain is exactly the same, even if there's not a primary nociceptive input. Their pain to the patient is exactly the same, so it's how the brain is perceiving this. So you really have to change the brain physiology. So it's really more of an educational thing. It's not anything you need to do to the nerves, so to speak. It's literally changing the way these people are understanding the inputs to their body. And with that education, often that fear and the exaggerated response, exaggerated not because they're wanting to be dramatic, but an allodynic response lessens tremendously.
Oh, interesting.
Yeah, it's pretty fascinating.
That's very fascinating. And, in all honesty, I don't treat a typical chronic pain syndrome yet. I mean, I'm still trying to get doctors to send me their incontinence patients on a regular basis.
Yeah, absolutely.
Instead of just, trying to go for the surgery. And something that I mean, this is a little bit off the topic of chronic pain, but I mean, in general, when you talk about the re-education of the nervous system, and how I deal with re-education of the nervous system all the time, whether it be through, dyspnea or incontinence, the urge incontinence, and having people develop new behavior habits, and breaking it down for them. What I've just found fascinating is as soon as I explain to them that is what's going on, that you've just fallen into this pattern, that you don't have to, your bladder's not going to explode, for instance, that you can override it. I've had patients time and time again where it's like, wow, there was a huge shift and a decrease in symptoms as soon as they, get that light on in their, just in their awareness of how things can be different.
Absolutely, you're absolutely right. That's part of exactly what we're talking about. That it begins with education, and we all do it as therapists, obviously, in so many ways. And I agree with you. That can cut down their symptoms by 20% before you've even laid a hand on them. Absolutely.
Right.
Yeah,
well,
we do
great.
quite a bit of that.
Yeah. So, when you are doing all of your chronic pain people, is it now going to be a standard where you don't do any manual therapies for a certain amount of treatments?
Yeah, it's a great question. We're really trying to figure that out. And I think originally, before this course, we were thinking that we would only incorporate this for patients who had very chronic pain and were presenting with symptoms of central sensitization. But I think after this course, it may be incorporated to anybody who has pain. Because our practice is probably 70% pain. That is how my business partner and I got into this, was treating pain only, very, very little incontinence. So we're starting to see more incontinence because it just comes in the door. But
yes,
it's so our background is quite a bit different than I think most PTs who get into this. So, but yeah. So to answer your question, I think we might start integrating this into every pain patient. I think it's really a big missing factor. There was another study to show that, or I think a lot of clinicians think, well, if I explain this to my patients aren't going to be able to understand. They're not going to get it.
Yes.
And studies have shown that we underestimate what our patients can understand and really grasp. So I think taking all that information, I think it's going to be really, really interesting to see once we start incorporating this more regularly, and in the next couple of years when we start to track what's happening. I think good results. Yeah.
Right. Well, I think that's so interesting. I often get frustrated when when I've had patients come to me after they've seen other physical therapists, and by explaining, the postural and the ergonomics and really how, their body works and breaking it down,
Yeah.
with the breath work and the core stabilization and, all this that we're talking about,
Yeah.
and really educating the patients. And I've been to other PTs and they haven't given me this information. And I've heard PTs say, oh, they're not going to understand, or they're not going to do the exercises that you give them. So they kind of have this indifferent response. And I think I would love to learn more about that study where we underestimate our patients, because I think we got to give them more credit to be more self-advocate. And I think that once you explain to them and give them the education, they're going to be more motivated to, if they know why they're doing something, they're going to be more educated and more motivated to actually do it.
Yeah. And I'm sure you find this in your practice. I mean, our patients are very motivated to get rid of their pain or their dysfunction, because it is so, it affects their life so severely. If you have urinary bowel sexual dysfunction, or you can't sit to have a meal with friends or family, it really affects your quality of life. So I find that my patients almost all of them are willing to do whatever I recommend, and they'll get on board and they'll say, whatever, you drive the train and just tell me what I need to do, because I need to get back to my life, and I need to get pain under control. So I think our patient population is a perfect population to try this on, because they're highly motivated and they're into it. So I think the trick is to educating ourselves as therapists to do this type of work. We're so manually based, and of course we do a lot of education and talking, but this is different. This is very specific. So we're really excited in our clinic to start this kind of training and figuring it all out, and creating different educational tools. Right now we're working on a PowerPoint presentation that we'll make available to patients that kind of talks through it, that they can go through it on their own as well, as kind of a home exercise program, if you will. So there's different things, because just to give them a book, like to give them Explain Pain, is an expensive book, A, and B, a lot of people don't really respond to just reading. They want something a little bit more interactive. So we're going to see what works.
Gotcha. Yeah, I don't have that patient population so much. I mean, you're definitely at the epicenter of chronic pain. And the people that I see are not at their wits' end quite yet. So I think, that's a little bit different, and it doesn't change my approach at all to really educating them, because I still see value in that. Yeah. So I worked in Portland, Oregon, where there was a vulvar clinic there, and I saw a lot more pelvic pain, the vestibulitis, the vaginismus, the vulvodynia, and those were clients that were kind of more at their wits' end, because they've seen multiple doctors, and it took a while to find the doctor who was able to name it and then give resources for it. So it's a little bit different. And, the field that we're in for pelvic pain it's kind of cutting edge, no matter what approach you're taking, because it's not so well known. You're in an exciting place because you have well established. And I'm sort of it's exciting too, albeit sometimes frustrating to get the word out and get the education out. But it's still exciting to enlighten the doctors and the population that this is an option. I mean, it's one of my favorite things to go to an exercise class with women and explain what it is, and that there are options, that after you have a baby and leaking, that's not just how it is. There are solutions, there are resources, and it's exciting to kind of be the conveyor of that information to women.
Absolutely. We were saying that this conference, I've been going to this conference for probably 8 or 9 years, and looking at it just 5 years ago to today, I mean, now we're 50% of our organization are physical therapists, and there wasn't one lecture for the 4 days that didn't tout the importance of physical therapy in this patient population by every discipline, any kind of, whether it was a sex therapist or a physician or anything. They just said, you know, PT is an integral and absolutely necessary part of this treatment plan. And 5 years ago, it was starting to be said, but we were, you know, giving the lectures and getting a lot of resistance. And it's so wonderful now to see that there is really much bigger acceptance of us and of what we can do for this patient population, which is really exciting. It's a great time, I think, for, you know, young PTs who have an interest in this field to get into it, because the door is now open, whereas even 5-10 years ago it was definitely not open. You know, it was a hard close. But now, you know, the door's open, there's a little bit more information, and if you can just find those few docs that get it and are interested in it, then you can really develop a wonderfully collaborative approach, which is just a really great thing, you know, as a medical provider, to have that collaboration. It's so gratifying as a clinician, and the patients, you know, have the best outcomes with it. So things are getting better for sure.
That's good. I know. Well, the pain doctor that we have, you know, Park City, Utah is not that big.
Yeah.
8,000, 10,000 people, and the pain doctor here, you know, I finally was able to get a meeting with him. It took a while, and once I did, he said, people come in with pain in their pelvic area, I just say, sorry, I don't do that. And I said, oh, well, now you have a resource, you know, hopefully we can start collaborating. So that is exciting. And I don't know how much more time you have, but I thought it also might be interesting for the viewers just to talk about the pelvic floor, and if it is in chronic tension or spasm, high tone, and trying to get it to relax. I'd be interested to hear your take on explaining why it's important to be able to completely relax and not just learn how to do a Kegel, but how to learn how to relax the pelvic floor.
Absolutely. This is one of the biggest myths in pelvic floor therapy, is that Kegels are the treatment for all pelvic floor dysfunction. It's absolutely untrue. In fact, what you said, high-tone pelvic floors, Kegels are almost to the point of contraindicated, in my opinion, because what we need to do is we need to normalize the tone of the pelvic floor through many different techniques. You know, starting externally and working internally, there's lots of techniques, and when we teach this to students, you know, whatever works is what you should do. We have, you know, 10 different techniques, but until the tone is normalized, you can't start training, or you can't start doing Kegels or any kind of up training, because the hypertonus is often the source of the pain and the dysfunction. And then if you have active trigger points in the pelvic floor, any kind of Kegel is going to aggravate that trigger point. So I would say that's the number one thing that we see. We see a lot of patients that have failed, you know, pelvic PT, and they often say, well, I was on an up training program or a Kegeling program, and my symptoms got worse. Well, that wasn't appropriate for them. If you have a low-tone pelvic floor, you know, leaking urine or something like that, it may be absolutely, you know, appropriate. But yeah, that is a huge shift in the pelvic floor world in the last 10 years. Huge shift.
Well, there was even a book out a while ago, and I don't remember if it was the V book or another book where they're talking about someone with vaginismus or vulvodynia, and they put their patients on doing just quick flicks, quick flicks all the time to, I guess their theory was that you were going to tire the muscle out into fatigue. And, you know, when I was trained, and my mentors were just saying, you know, they asked me to read that book and say, you know, what do you think of that? And just intuitively knowing what I know about the body, I was skeptical of that technique. And lo and behold, you know, as time goes on, in, you know, even just through my own experience of treating people and then reading the studies, that's really not helpful.
Nope, it doesn't work.
No, it does not.
It doesn't work. No, it doesn't tire it out. You know, the pelvic floor muscles are not like your biceps or your hamstrings. No. These muscles are working all the time, so we maintain continence. So you are never going to get a perfectly relaxed pelvic floor. So when you have a pelvic floor that's hypertonic and you continue to do concentric contractions, that pelvic floor is just going to get tighter and tighter and tighter until it doesn't know how to relax. And that we see this with postpartum women all the time. They do their Kegels after they have a baby because they're told you're going to leak if you don't, and they overdo it. And then they come into our office and they're like, I've been doing what I've been told. And we get in there and in their pelvic floor is just as tight as, tight as anything. And what we have to actually do is relax the pelvic floor so they can regain motor control. So they actually have the range of motion to contract. Yeah, this is a big point a huge point in the pelvic floor. Well, I'm glad you brought it up.
Yeah, and I think it's interesting, when you think about, if a muscle has, this much range of motion from, all the way open.
Yep.
And if you're not getting it to go to that fully relaxed place, and you're only exercising right here, that's not functional. And that's true for any muscle in the body.
Correct.
But what's different about the pelvic floor, and it's similar to the jaw muscles, because that's another thing that I see often working together, is jaw tension and pelvic floor tension.
Yep.
Is that there are muscles that are really hard to relax, and if you start turning them on, it takes, because when we're exercising and we're running it to dissipate excessive energy, that's not touching our pelvic floor. So it's not one of those muscles, it's not one of those areas that can just dissipate and like flush out the excessive tone. So it behaves somewhat like other muscles in the body, but then it has its own rules.
That's right.
Yeah. Yeah.
Well, I'm so sorry I have to run to another patient.
No,
This is fun. It was great to talk with you, Heather.
It was great. Thanks for the time, and thanks to Therapydia for putting this on.
Thank you so much, Alex.
Yeah, thank you, ladies, for joining us. And if you want to learn more from Heather or Elizabeth, you can connect with them on the site.